హలో
Sir, good morning, sir.
గుడ్ మార్నింగ్ అంటారు రెడీయా
నేను రెడీ మీకు మళ్ళీ కొత్తగా పంపించాను. ఇన్ కేస్ ఏదైనా ప్రాబ్లం అవుతే అది స్టార్ట్ చేయండి.
అలాగే అలాగే ఇప్పుడు వస్తుంది కదా నీకు ఎలాగో
ఇప్పుడు వస్తుంది చేశాను.
మూవ్ చేయి స్లైడ్స్
ఒక్క నిమిషం స్టార్ట్ చేసి కదా అది కొంచెం తీసి మామూలు పెడతాం.
మూవ్ అవుతుంది
ఓకేనా?
ఫస్ట్ స్లైడ్కి వెళ్ళు స్టార్టింగ్
ఓకేనా?
ఓకే కేస్ సినారియోసా
అంటే 2 కేసెస్ ఓటీలో అయినవి కొంచెం ప్రాబ్లం అయింది. సో ఆ కేసెస్ ప్రేమ్ చేసి దానికి రిలేటెడ్ గా టాపిక్ అందుకే అది అప్పుడు అలా చేసి ఉంచింది మాట. ఇప్పుడు అవన్నీ మళ్ళీ మార్చాను. సో క్రిటికల్ కేర్ రిలేటెడ్ కొంచెం యాడ్ చేశాను. అనెస్థీషియా రిలేటెడ్ కదా.
అదేలే వీడియో పెట్టలేదంటే
నేనా 5 minutes పెడతా. ఇప్పుడు ఓకే సార్?
ఓకే
సౌండ్ సార్ ఆడియో
సౌండ్ ఇస్ గుడ్.
ఓకే.
వెనక లైట్ వేసిందా వెనక
పైన ఆపేనా?
అది ఆపు.
ఇప్పుడు ప్రాబ్లం ఉందా?
ఇప్పుడు బాగుంది.
ఓకే. ఏసీ ఆన్ చేసి
ఇంట్లోనే కదా. ఇంట్లోనే కదా. Bashir, make me co-host. Bashir.
Good morning, David.
గుడ్ మార్నింగ్.
Mm.
ఏంటి సంగతులు?
గుడ్ మార్నింగ్ సార్. గుడ్ మార్నింగ్ సార్, సతీష్ సార్.
అమ్మా గుడ్ మార్నింగ్ అమ్మా.
ఎలా ఉన్నారు సార్?
బాగానే ఉన్నామ్మా, నడుస్తుంది.
ఎలాగైంది సార్ ఎక్కువ?
నడవటం ఏంటన్నా, పరిగెట్టాలి కానీ.
లేదు, వయసు అయిపోయింది.
నడవటం అంటావా? ఫాస్ట్ గా నడవాలి కాకపోతే.
అంతే. ఇంక మనం రూములు బుక్ చేసుకోలేము.
అవును,
అబుదాబిది.
అక్కడ ఏదో ఇది ఇస్తారంట కదా, ఒక ఏంటది సర్వీస్ అపార్ట్మెంట్ లాంటిది.
అంటే వాళ్ళని క్లీవ్లాండ్ వాళ్ళని కాంటాక్ట్ చేస్తే అవుతుందా అది?
ఒకసారి కనుక్కోవాలన్నా.
అదే అదే అందుకనే.
లేదండి నీలోఫర్ మరి దగ్గరలోనే బుక్ చేయాలి కదా, మరి దూరం అది అంతా మన కంట్రీ మొత్తం కలిసి సిటీ అంత ఉంటుందిలే.
ఇవాళ మెసేజ్ లో గ్రూప్ లో డిస్కషన్ పెడితే విషయం తెలుస్తుంది సాయంత్రానికి.
అలాగే అలాగే.
ఓకే.
వాళ్ళు మెటీరియల్ ఏం పంపలేదంట కదా?
ఏం రాలేదు మరి ప్రస్తుతానికి కదా.
గుడ్ మార్నింగ్ డేవిడ్ గారు.
సార్ గుడ్ మార్నింగ్.
ఏంటి సార్, ఏంటి వెబినార్స్ మీద వెబినార్స్ కండక్ట్ చేస్తున్నారు? నిన్న ఐఏసీఎం, ఈరోజు
ఇది రెగ్యులర్ కదా సార్, ఆపేయమంటే ఆపేస్తాం. అందుకు వెబినార్స్ ఎక్కువ అయిపోయినాయి, రెస్ట్ ఇద్దాంలే ఈ వీక్ అంటే నిన్న చెప్పుండాల్సింది కదా ఆ విషయం.
సార్ 89 చాలా డిఫికల్ట్ అవుతుంది సార్ యాక్చువల్ గా. మరి మిగతా వాళ్ళకి ఎలాగవుతుంది తెలియదు కానీ మాకు అలా టైమింగ్స్ మాకు టైం కుదరట్లేదు ఎటు గారు.
తప్పదు కదా.
అదే ఏదో రోజు చెప్పితే టైంలో అవ్వాల్సిందే అంతే కదా.
స్టార్ట్. Good morning all of you. Today Dr. Anuradha Saramanda, she is the head of the Department of Anesthesiology and a consultant in Critical Care Hospital, Visakhapatnam. She is going to talk on stress cardiomyopathy with showing some case presentations in her hospital. Now I request Dr. Anuradha to start the presentation. హలో
సార్, గుడ్ మార్నింగ్ సార్. సార్ ఈ సైడ్ వీడియోస్ వస్తున్నాయి, ఏం చేయాలి వద్దు అనడానికి?
ఎక్కడ వీడియో? మాకేం రావట్లేదు ఇక్కడ.
అంటే నేను వీడియో ఆన్ చేస్తూ వచ్చింది, ఒకసారి ఏదో చేస్తాను. ఓకే, స్లైడ్స్ సైడ్
మాకు ఇక్కడే డిస్ప్లే రావట్లేదు.
ఓకే,
యు స్టార్ట్.
Good morning, my seniors and my colleagues and students. Today I am presenting the stress cardiomyopathy. So we have two cases. So we diagnosed and we treated and discharged the patient. So I am presenting today. So this is my first talk in critical care Morton group. So in the presentation, my outlines are case reports and pathophysiology and precipitating factors, imaging and management and conclusion. So this is the 64 years male patient complaining of back pain for the last 4 years, weakness of lower limb and diagnosed with lumbar canal stenosis, L4, L5 disc prolapse. Posted for surgery, laminectomy and discectomy. And during PAC, no comorbidities. Interrupt during the procedure, the patient had brady and blood pressure fluctuations. And post-op elective ventilation and inotropic support, we started noradrenaline and the ECG wide QRS complex, RBB present, and a cardiology consultation has been given, and the echo Vico global hypokinesia, and a severe LV dysfunction. And post-op 0, we started a central line and arterial line placed, and dobutamine and nardrolone also continued. And the patient kept on lanaxin, aldactone, ecosprin, carnita, thiamine, and tropi 2970. And day 1 post-op, same treatment continue, and then day 2 echo repeated. So mild LV dysfunction at 3:20 p.m. patient extubated and connected to NIV and inotropes to V0. And day 3 removed central line artery and shifted to room day 4, and day 5 is dischargeable with the cardiac medications. This is the female 55 years complaining of upper abdominal pain, radiating to the back for the last 6 months and vomiting. Diagnosed as a cholelithiasis, acute pancreatitis. ERCP done under short general anesthesia. And the next day, following day, posted for lap cholecystectomy. Intra hemodynamically stable and extubated. After 5 minutes, patient developed hypertension and pulmonary edema. Pulmonary edema, and electively intubated and connected to mechanical ventilation, and injection Lasix given, and focus has been B-profile positive. Patient shifted to SICU. Patient had tachycardia and hypertension. Suddenly, patient had severe hypotension, systolic 70, and fluid resuscitation started, but they did not improve the pressures, and noradrenaline started. And emergency femoral arterial and central line placed, and cardiology consultation given, and echo done is severe LV dysfunction, dobutamine IMAX started. Propicent and cardiac medications advised. After 3 hours, patient was hemodynamically stabilized, ABG correction done. And day 1 is a patient on prayer support with inotropic support. And 12:30 p.m. patient extubated and connected to NIV. And day 2 is NIV and dobutamine. And day 3 is dobutamine and VNAF and shifted to ROM. And day 4 discharged with the cardiac medications. This is 2 cases we happened like this, diagnosed as a Takasubo syndrome. So going to the Takasubo syndrome, it transient left ventricular dysfunction, but without evidence of obstructive coronary artery disease. It is first described in the 1990 in Japan. In Japan, this is it is look like a pot. It is using for trapping the octopus. So during the transient LV dysfunction, our left ventricle look like a Takasubo, pot like. So that's the name given, Takasubo syndrome. So various names are present: stress cardiomyopathy, broken heart syndrome, apical balloon syndrome, ampulla cardiomyopathy, transient left ventricular dysfunction syndrome, neurogenic stunned myocardium, reverse Takasubo, inverted Takasubo. These are the other names of Takasubo syndrome. So in a revised Mayo clinical criteria in 2008, it transient hypokinesis, akinesis, or dyskinesis of the LV mid segments with or without apical involvement, and often of stressful triggers, absence of obstructive CAD, or angiography evidence of acute plaque rupture, new ECG abnormalities, either ST elevation or T inversion, or modest elevation of profile, absence of preiochroma or myocarditis. So I'm keeping the yellow liner words is our 2 patients get these symptoms, signs, so that's why I marked it like a yellow thing. And this is the diagnostic criteria in the Heart Failure Association of European Society of Cardiology criteria in 2006. So we are using revised Mayo clinical criteria. Going to the pathophysiology, here stimulation of a sympathetic nervous system, so release of adrenal from the adrenal gland. So this leading to patient developed increased vasoconstriction or contractility of the cardiomyocytes and increase the heart rate. Here what happened? Here catecholamine surge present. So increase the catecholamines. So patient is asked in the heart. So coronary vasospasm, microvascular dysfunction, and acute myocardial dysfunction and inflammation occurs. So high level of epinephrine signaling takes place through the pleiotropic 2 adrenergic receptors, that is 2AR, from a canonical stimulatory G protein, activated cardiostimulant to inhibitory G protein activated, and cardiodepressant pathways. Here, majority of beta 2 receptors located in the LV apex area. So, alter the intrasensory signaling as cause of the apical ballooning appearance. So, most of the beta receptors are present in the apex area. That's why here what happened? It is akinesia, hypokinesia, dyskinesia occurs. So, it is a look like a ballooning. And here what happened? Here surge is present. So, increase the stimulation. So hyperkinetic, the basal part. So we can take it, this part is a basal, this part is a mid, and this part is a apical. So different varieties you can see. Apical ballooning type is a type 1. Here what happened? So apex area is a ballooning. Mid-ventricular wall motion pattern means mid part is a hypokinetic. This part and basal part is moving. And the basal wall motion means this part is moving, this part not. Sorry, this part is not moving. This part is normal. And the focal wall motion pattern, that means only one area is hypokinetic or akinetic. Sometimes we can see the biventricular. That means RV also involved. Going to the endomyocardial biopsy, it is look like an interstitial infiltrates with mononuclear lymphocytes and macrophages and contraction bands. Extensive lymphocytic infiltrates and multiple first contraction leads to band necrosis. So you can send for a lab investigation. So first is the ECG for identification. So in the ECG, we can see the ST depressions, elevations, and the prolonged QT prolongation more than 500 milliseconds. So it is normalized within 48 hours. So in the echo, so we can see the apical ballooning. That means this is the basal part. This is the basal part. This is the mid part, and it is the apical. This part is not moving. So this is the here LV thrombus is present. This part is a basal part and mid part. This is apical part. Here apical apex is not moving. That's why the chances of thrombus is present. So a LV apical thrombus is present. So that we have to immediately start the anticoagulants. So in CMR is the cardiac magnetic resonance imaging. So here you can see in the cases of coexisting CAD or echo, poor visualization, cardiovascular magnetic resonance can be replaced. The absence of late gadolinium enhancement and CMR provides against the AMI and myocarditis. So in fact, inverse flow and metabolic mismatch due to a discrepancy between the normal perfusion and limited glucose metabolism in dysfunctional areas is seen in myocardial positron emission tomography scan in Takasubo. So these are the investigations: ECG, biomarkers, creatine kinase MB, and transthoracic echo, cardiac magnetic resonance, and the coronary angiography. So in ECG, we are seeing that in Takasubo, we can see the ST elevation with the prolonged QT intervals. In biomarkers, troponin is mildly elevated, and PKMB also mildly elevated, but in pro-BNP, BNP is highly elevated compared to ACS and myocarditis. And in coronary angio, culprit coronary artery is not seen, it is normal. But in the ACS, culprit coronary artery block we can see in the coronary angio. That is the comparison between the Takotsubo and MI. So what are the stress factors in a stress cardiomyopathy? It is emotional stressors and physical stressor. Emotional stressors is most common in a female patient and post-menopausal patient because estrogen levels are reducing, deprivation that leads to endothelial dysfunction in the post-menopausal women, more than 50 years, 55 years. And emotional stressors like death, relatives or friends, and interpersonal conflict, job issues, financial issues, gambling loss, anger, frustration, panic, fear, anxiety. So in yellow highlighting, that is the our patient have these signs and symptoms. Diagnosis of malignancy, bad news, daughters divorce, spouse leaving for war, legal proceedings, robbery, public speaking. And physical stressors like post-surgical, cholecystectomy, hysterectomy, infections, fall, chemotherapy, thyrotoxicosis, stroke, subarachnoid hemorrhage, seizures, abdominal pain, diverticulitis, colonoscopy, severe pain, renal colic and fractures, cocaine users, and opioid withdrawal, dopamine stress, intranasal phenylephrine. So here, mental stress and physical stress that gives the catecholamine surge. So it leads to impaired myocardial perfusion, myocyte injury, LVOT obstruction. And here, perioperative triggers. That means when patient posted for surgery, what are the triggers as well? Inadequate depth of anesthesia, local or general, tracheal manipulation during intubation and extubation, parasympathetic denervation in the area of pulmonary veins, post radiofrequency ablation for initial atrial fibrillation, and exaggerated response to catecholamines due to selective sympathetic denervation in a transplant heart, exogenous administration of epinephrine or other catecholamines, release of inflammatory media due to anaphylaxis, abnormal myocardial functional architecture that predisposes to a patient to LV outflow obstruction in the presence of hypovolemia, high intrinsic extrinsic catecholamine load, extreme hemodynamic and pulmonary compromise in the perioperative period, excessive carbon dioxide absorption during laparoscopic surgery, use of ergotamine after cesarean section, cardiac arrest due to other causes, direct spinal cord stimulation during placement, removal of spinal cord stimulator, and autonomic dysregulation during after electroconvulsive therapy. These are the triggering factors of stress cardiomyopathy. So you go see the comorbidities like obesity 17% chances, hypertension 54%, dyslipidemia 32%, diabetes 17%, smoking 22%, psychological 24%, pulmonary disease 15%, malignancy 10%. So when you are taking the see the patient, you can diagnose the criteria of Takotsubo from ACS. You can exclude this one. So you can go for inter-Takotsubo diagnostic score. In female is 25 points. You can give the 25 points. Emotional stress 24, physical stress 13, no ST depression 12, psychiatric disorder 11, neurological disorders 9, QT prolonged 6. If score is more than 70, is a high probability of Takotsubo. Less than 70 is the intermediate low of Takotsubo. Some books are given 50 points also. So in arrhythmias, so in Takotsubo, it is mainly catecholamine surge. So that is a effect on cardiomyocytes, either neurogenic or catecholaminergic stunning process. So irreversible cellular injury occur and the patient develop arrhythmias. Some no arrhythmia 78%, atrial fibrillation 11%, and the paracini supraventricular tachycardia 5%, atrial flutter 1%, ventricular tachycardia 2%. Our patient has supraventricular tachycardia. So in stress cardiomyopathy, you can divide as a primary stress cardiomyopathy and a secondary cardiomyopathy. So primary stress cardiomyopathy means patient in a cardiac ICU, already cardiac ICU patient. Secondary cardiomyopathy means already a patient in a medical or surgical neurological critical illness. After 1 or 2 days, developed stress cardiomyopathy. So that is the difference of primary and secondary. So if presentation at home is in a hospital, and the clinical picture is the angina, dyspnea, ischemic changes, and troponin elevation, arrhythmias, hypotension. At admission, negative catheterization echocardiography, and in a secondary stress is ICU during echo, and the troponin ECG elevations. So you can see the different types of apical, ballooning, mid-ventricular, basal, focal, global. And here also same you can see, but in secondary stress cardiomyopathy, 50% chances of apical ballooning, 10% mid, and global hypotension 10 to 40%. Here primary is very compared to secondary is the primary is very less percent. So cardiac catheterization is the first indication. 90 to 100% is the primary. Only 20% because patients are in a critical illness in other problem. So that's why we cannot send the cath lab. And the patient 9.9% of shock in primary and 30 to 69% of secondary stress cardiomyopathy. Mortality 4.1%, but mortality 35 to 50% in secondary stress cardiomyopathy. So how we can see the diagnose the stress cardiomyopathy in a patient in diagnostic algorithm. We can go for patient complaining of chest pain and dyspnea. First, you are seeing the ECG. Any elevations are present, go for angiography. If no elevations, you go for inter-Takasuba diagnosis score. Any points less than 70 or more than 70, you see the echo, transthoracic echo, and see the LV contractility. Patient is stable, go for CTCA. If not stable, see the patient chemical condition, any LVOT obstruction is there, or any MR is there, any RV involvement is there, and go for angio. And the CAD, any CAD history is there or not, you have to see. Here, coronary culprit, anything is there, and regional valve motion abnormality is there or not, you have to see. If regional valve motion abnormality is there, you diagnose with the ACS. But here, absence of Takasubo features and in CE, LV is normal, so you can diagnose the myocarditis. Any persistent regional motion and it is reduced after 2-3 days means that is Takasubo. It continues regional motion. You can diagnose, go for CMR. You can diagnose the ACS or myocarditis or TPS. So in our patient, in the presentation, a patient on that time is a ventilator, one patient. So we cannot see the chest pain dyspnea. So troponin positive LV dysfunction is present. So any critical patient in ICU, medical, surgical, neurological patient, any cardiac troponins are the elevation. So you can see the patient, it is acute angina or troponins elevated or ST elevation, and patient cardiogenic shock is present or not. If cardiogenic present, go catheterization, and CAD, if CAD, go for revascularization. If no CAD, possible of stress cardiomyopathy. So you can see the apical balloon in echo and apical ballooning. So if only mildly elevated ECG, ischemic changes, hemodynamically stable, mild heart failure. So we'll see for echo, and accordingly we can go start the treatment. Suppose basal or regional motion, mid or complex, so probably stress cardiomyopathy. Repeated echo and for 5 days. So if contractions are slowly improving, means that is you can diagnose as a stress cardiomyopathy. So differential diagnosis you can in of stress cardiomyopathy is you can think like a myocardial infarction and myocarditis. Here symptoms are chest pain, dyspnea, syncope, and sudden cardiac death also, arrhythmias also present, and a history of emotional stress factors are present, physical factors. And here on my MI, arrhythmia, sudden cardiac death, in myocarditis also same symptoms are presentation. In ECG, ST elevations and depressions, T wave inversions, QT prolonged. Here ST elevations and same presentation. Here myocarditis is non-specific. Echo, we are doing echo, apical, mid and focal and basal akinesia, you can see. Here reasonable motion, particularly one area. So in angiography, absence of obstructive CAD. Here you can see the coronary artery diseases. And the myocarditis is the absence of obstructive CAD. And CMR, you can see the edema and no DG, delayed gadolinium enhancement. Here positive present. Here only biomarkers, anti-probunin B, BNB highly elevated, mildly elevated, troponin, CKMB. Here CKMB, troponin highly elevated. Here also mildly elevated. So complications. LV function returns to normal within few weeks in a stress cardiomyopathy patient. But during the stress time, patient may develop acute heart failure and cardiogenic shock at 12% to 45%. LV outflow tract obstruction for 4% to 25%. Arrhythmias like atrial fibrillation, you can see 5 to 15%. And ventricular arrhythmias, you can see 4 to 9%. And LV thrombus 2 to 9%. So 2 to 5 days after symptom of onset, the LV thrombus is developed. So that is going to systemic cerebral vascular embolia is 17%, and the systemic thromboembolism, intramyocardial hemorrhage and rupture, it is a very rare condition. So now going to the management. So here our patient with the first line treatment given sedation, anxieties, and analgesia for therapy. If possible, beta, alpha and beta blockers to reverse the catecholamine toxicity, avoid unopposed beta blockade. If hypotension, cardiogenic shock, first see the LVOT obstruction or LVOT without obstruction. If LVOT obstruction is there, so stop inotropes, give the fluid resuscitation. If LVOT no obstruction, so you can start the inotropes. So, and second is early consideration of mechanical cardiac support like IABP and LVAD, Impella to decompress the LV and bypass the LVOT, and if a pulmonary edema, go for diuretics. So these are the algorithm if you are diagnosed the stress cardiomyopathy. So see the pulmonary congestion is present and cardiac. If pulmonary congestion without low cardiac output, we treat like a heart failure, like a venodilator, nitroglycerin, nitroside, nitroprusside. With the hypertensive patients, AC inhibitors, ARB block, and beta blockers like metoprolol, we can start. If pulmonary edema congestion is there, you can go for plus or minus diuretics. This is the treatment we have to start. Now is a cardiogenic shock is there and low cardiac output. First you diagnose the LVOT obstruction is there or without LVOT. If with the LVOT obstruction means avoid inotropes, see the relievers and start only give IV fluids. If necessary, beta adrenergic blockers and metoprolol, esmolol, and if need, vasopressins like phenylephrine, vasopressin. But without LV obstruction, supportive care, inotropes like dobutamine, milrinone, dopamine, levosimendan, and vasopressins if needed, phenylephrine, vasopressin. So you see the echo monitoring and evaluate the cardiogenic shock. If LVOT obstruction is present, how much MR is there? So that also causes more LV dysfunction. So assess the apical balloon. If apical is akinetic, so chances of thrombosis. So start the anticoagulants as early possible, and the thromboembolic risk also is present. If LVOT obstruction, you go for ECMO. If LVOT obstruction is not there, but inotropes you are started, but it's not improving, you go for IABP or LVAD and anticoagulants. These are the treatment of stress cardiomyopathy. In heart failure, you can see the mild heart failure, mild Takotsubo. You can AC inhibitors, ARB beta blockers, and pulmonary edema is a plus or minus diuretic if LVOT obstruction is not there, and NTG. And hypotensive patients see the obstruction or pump failure. If pump failure, go for LVAD, ECMO, and LVOT, obstruction, IV fluids, beta blockers, avoid diuretics, nitrogen, IABP. And any arrhythmias, so consider beta blockers and temporary RV pacing and a light rest. Avoid QT, interval prolongation drugs, beta blockers, and permanent devices. And thromboembolic events, go for consider heparin, vitamin, anticoagulants. Consider the anticoagulants less than 30% and large LV, so involving the apex preserve. If you can continue the treatment for 3 months until symptoms are subside, and go for the same treatment. And you have to support the coronary arteries, aspirin and statin, and congestive, and you can relieve the psychological support like depression, anxiety, and psychiatric referral, and cognitive behavioral therapy, antidepressant, anti-anxiolytic medications you can start. And the recurrence prevention is AC inhibitor ARP. So my summary key points are Takotsubo cardiomyopathy mimics the presentation of acute MI, treat as a acute MI. It precipitates the emotional, physical stressors because of abnormal response to high catecholamines. It's more chances of a postmenopausal woman, and females are more than 50 years, 55 years. Males are more than 50 years. And several patterns of LV wall motion abnormalities we can have seen, and the elevation of cardiac enzymes, and cardiac catheterization is a confirmatory, which reveals a normal coronary. Coronary microvascular dysfunction is implicated. We have to give the supportive care and the acute heart failure management. So these are the articles I read. So these are the referral points. Thank you so much.
Very good, Anuradha. So when we are all going to learn ECMO of EV ECMO, and you people are going to learn VA ECMO, because you are more interested in cardiac this one, you should be doing only VA ECMO more and more, right?
Yes, sir. Sir. So these two cases, we crossed the stress cardiomyopathy. First female patient, cholecystemic patient, we diagnosed and extubated, immediately intubated because of pulmonary edema, tachycardia. So we treated like this. And after 2 days, second case patient developed, that is male patient, for spinal surgery. So we treated in post-op with cardiology help. So we discharged like this. So we come across 2 cases. That's why I present this one.
Anuradha, how do you prevent stress cardiomyopathy rather than treating?
So already, so physical stress means males more common, sir. So how to manage and means we have to reduce the physical stress, sir. And emotional stress also we have to so anger, anxiety, fear.
No, that is the reason we strongly focus on pre-NC checkup and proper pre-NC checkup by the consultant and evaluation and training them and also explaining them. Those things will, psychological stress, everything will come down. And as I said, all the 4 components of pre-NC checkup, if we include, that will reduce. And as I said, another third point is intraoperative correct monitoring of continuous, how you normally in the CTOT you monitor the ECG 12 lead, doing all these things for high risk cases. And those things anyway will do. Those things will prevent, is my opinion. I don't know. You can check it.
recent history of any emotional trauma, like recent loss of any family members and all, even that cases should be avoided for elective surgery, I think.
So these are the things selectively we are pre-op only. We have to take the history, and accordingly we have to counsel the patient, sir, and patient family also. And in the ICU, already critically ill patient is admitted for some other problem. And after 2-3 days developed a stress cardiomyopathy, that means a secondary stress. So that also we have to take at the history and proper investigations and everything we have to take it, sir.
Nice presentation, Anuradha.
Thank you, sir.
Yes, as you said, to prevent the stress cardiomyopathy, identify the patient who are more anxious about the surgery, or patient is very stressful patient. This patient can be counseled properly, and preoperative anxiolytics and then post-operative anxiolytics sedatives should be continued to avoid this type of syndrome. From my side, one question is that if patient is post-operative developed severe LV dysfunction, we don't know whether it is myocarditis or stress cardiomyopathy or acute MI, because patient is having ST elevation, troponin elevated, patient in shock. Okay.
Yes, sir.
So how do you differentiate? You said the differentiation is by coronary angiography or CMR, cardiac MRI, right? But patient is
Yes,
not
sir.
fit for shifting the angiography or MRI. Then how do you treat this patient? Patient is post-operative. You
Sir,
cannot start.
patient in post-operative cardiogenic shock. First, you have to take the ECG and echo, sir. In transthoracic echo, you can see the LV function. Any reasonable motion abnormality is there or not, you have to see. And a patient have tachycardia, and the reasonable motion abnormality is one area or whole LV is reasonable is present or not, we have to take care and start the inotropes and see the LVOT obstruction is there or not. If LVOT obstruction is not there, you can give the fluids resuscitation and inotrope support. If obstruction is there, stop inotropes, first fluid resuscitation and control the heart rate. If not controlling, go for other mechanical supports.
Yeah, even Takasubo also having RWM, you know?
Yes, sir. So sometimes, I mean,
yeah, sometimes,
most
some
commonly
cases. Most commonly, you will see the whole area apex and mid is dilated and not contracting. But sometimes
yes,
some patients having RWMA, in that scenario, we have to start, if it is MI, you have to start the antiplatelets and anticoagulants. But it is post-operative case, we cannot start. And to differentiate the Takasubo or MI, patient in shock, we cannot shift for angio or we cannot shift for MRI. In that scenario, and patient is also
we are
having
not shifting the patient to cath lab. So that's why we have to start the IV fluids and the inotropic support. If BP is maintaining, it's okay. If not maintaining, we go for the mechanical supports. And it's still deteriorating. We have started everything but not controlling. So we had started mechanical support. If BP is maintaining, every day you have to see the echo findings. Slowly is picking the LV reasonable motion abnormalities reducing, means that is stress cardiomyopathy. Is not revolving ST elevations is they come, that means you can think is a MI.
Thank you. Any questions? Hello?
Nice presentation, madam.
వాటికి మీరే క్వశ్చన్ చేయాలి సార్.
Thank you, sir.
Madam, can you get this kind of these things in the intensive care unit? Those on
Yes, that's why it is a secondary, primary, secondary, sir. Secondary stress cardiomyopathy means patient already admitted for another illness, that is a medical or neurological or surgical problem. He admitted. After that, patient developed stress cardiomyopathy. That is secondary. That's most common. Common, sir.
Yeah.
So in a critical ICU also we have to take care. And I think David sir, do you remember or not? Neuro ICU, one patient. After 2 days,
I
we
remember.
unable to extubate.
Post liver transplant case developed stress cardiomyopathy.
You are unable to extubate. You're told to echo, severe LV dysfunction, pulmonary edema. You started dobutamine. And after that, you extubated everything. I think it is a maybe.
Everybody thought it was MI, but it was not.
Yes, sir.
Yes, sir.
And
so it's a most common, sir.
Most commonly in medical ICUs, patient presented with infection like pneumonia or some other infections. First 2-3 days, patient having now good LV function, everything is fine. Suddenly on 4th day, patient developed severe LV dysfunction, global hypokinesia, pulmonary edema, hypotension, all these patients. So in this case, how will you differentiate whether it is myocarditis or stress cardiomyopathy?
In stress cardiomyopathy, pro-BNP and BNP is a high level, sir, compared to troponin levels. And the myocarditis is almost mildly elevated, not too much. In the MI, tropi and everything is increased compared to pro-BNP. So you can differentiate MI
the pro-BNP
and
levels will be
very high in stress cardiomyopathy, and troponin levels are mildly elevated.
Moreover, in myocarditis, most of the time we'll find global hypokinesia. Yes, sir, David Garu?
Yeah, global hypokinesia. The main differentiation here is the basal levels contracting vigorously in stress cardiomyopathy, and the rest of the thing is ballooning, like it's like balloon, mid and apex. But the basal segments are contracting vigorously. But even in myocarditis also, sometimes we will see basal levels are contracting well, and inferior and posterior wall contracting well, and rest of the thing is dilated. So we cannot 100% differentiate by just looking at the echo and ECG. But the treatment is same. There is no, I think there is no difference in treatment. Only thing, as Anuradha said, she is not mentioned about noradrenaline or adrenaline for hypotension. She mentioned about only dopamine, dobutamine, vasopressin, and phenylephrine. Why, Anuradha, why adrenaline or noradrenaline are contraindicated in stress cardiomyopathy?
Okay, actually, adrenaline noradrenaline is catecholamines. So already this patient have surge of catecholamines. We are introducing adrenaline means that is more chances of increasing the
Worsening
stress.
the, yes.
Chances of worsening of the LV, and we are increasing the contractive myocyte injury also.
We should not start noradrenaline or adrenaline. So in case of patients admitted in sepsis, developed hypotension or shock, global hypokinesia, then before starting the noradrenaline, we have to differentiate the stress cardiomyopathy or myocarditis. Okay?
Yes, sir. Yes.
Any questions from sir? Patient post-operatively having LV clot, post-operative, what is the treatment of choice?
LV thrombus means anticoagulation starts.
Patient post-operative, immediate post-op. Next day he had LV clot.
కాదు డేవిడ్
సార్
పోస్ట్ ఆపరేటివ్ క్లాట్ నువ్వు అన్నట్టుగా థ్రాంబులైజ్ చేస్తే బ్లీడ్ అవుతుంది కదా, బట్ ప్రొసీజర్ చేయొచ్చా?
థ్రాంబోలైజ్ క్వశ్చనే లేదు అసలు. దేర్ ఇస్ నో రోల్ ఆఫ్ థ్రాంబోలైసిస్ ఇన్
పోస్ట్ ఆపరేటివ్.
పోస్ట్ ఆపరేటివ్.
అందుకే థ్రాంబులైజ్ కాదు చెప్పేది, ఇంటర్వెన్షన్ చేయొచ్చా అని అడుగుతున్నా.
ఇంటర్వెన్షన్ ఎల్వి థ్రాంబస్ చేయలేదు సార్.
ఇంటర్వెన్షన్ లైక్ కరోనరీ యాంజియోగ్రామ్, అదేగా మీరు అనేది. ఫస్ట్ ఇన్వెస్టిగేషన్ ఆఫ్ చాయిస్ ఈజ్ CT coronary angio, so that we can avoid this heparin or this antithrombotics. There, if you find something, then you can go for conventional angiography. If patient develops LV thrombus, we have to leave it. That's all. We cannot give any antiplatelets. The patient will bleed.
Anticoagulants we have to start, sir. Otherwise, it will cause the cerebral vascular.
Post-op case immediately. Open cholecystectomy. Bleed అవుతాడు కదా.
One day we have to wait, sir. Until surgical bleed, no bleed, it's okay. So you can start.
Okay. Actually, go to the history of this Takotsubo syndrome. First, it was identified in Japan in around 1940s due to Second World War time. There was an incident of earthquake. So many relatives and near loved ones are dying in front of these persons. So instead of dying of patients with injuries of earthquake, more people died due to by watching these dying people due to injuries. So who are not injured, just they are watching the persons who are injured and dying. These persons who are watching the scene of incidents, they are dying more. That time these patients were admitted and investigated. That time they found that this is a stress-induced cardiomyopathy and deaths. That time they recognized this Takotsubo syndrome in 1940s. Due to severe emotional stress and anxiety, fear, this syndrome is happening, and they identified it during 1940s in Japan. Before that, it was not diagnosed. Hello?
కాదు డేవిడ్, అదంతా మాలాంటి హార్ట్ ఏంటది, మీలాంటి హార్ట్ ఏంటది? అంత మాలాంటి హార్ట్ ఏంటది, మీలాంటి హార్ట్ ఏంటది?
అయి ఉంటదా?
అదే సార్, మాది వీక్ హార్ట్ కదా, మీలాగా స్ట్రాంగ్ హార్ట్ కాదు కదా.
సార్ హార్టే సార్, ఎవరికైనా
హార్టే సార్. అది చెప్పడం కాదు. అంటే ఇప్పుడు సపోజ్ some ladies there, his son is dying due to roof collapse in front of her eyes. Adi we cannot expect. We cannot say my heart is strong, somebody heart is weak like that. That time, how much means emotion? But that's why this is called. Another name is the love heart syndrome. Something is there because of somebody is dying. It's not an issue. They don't take much. But their wife or husband or son or father or mother dying due to in front of their eyes, immediately now in the Vijayawada incident was there, no, that one daughter they was killed. ఎందుకంటే ఫాదర్స్ డే కూడా పెట్టారు కదా, అది నేషనల్ ఫాదర్స్ డే. సో ఆఫ్టర్ హియరింగ్ దట్ న్యూస్, he developed severe chest pain and he collapsed immediately, admitted and intubated, severe LV dysfunction, he died. So this type of things we cannot predict before. I don't think we can control that emotion at that time.
సార్ అందుకే కదా సార్ షాక్ ఉన్న వాళ్ళకి పిఎస్సి చెప్పే వాళ్ళకి మొత్తం ఈ నోవల్ 4 కాంపోనెంట్స్ ఇస్తాము. Intraoperative, we give not only the sedation and analgesia and all the components has been covered, and post-operatively we should aware of all the vitals before, because we only look at the particularly for anesthesiologist. మీరు గమనిస్తే ఇప్పుడు కార్డియోమయోపతి ఇప్పుడు మీరు చెప్పిన టొకసాబు or stress cardiomyopathy, because of the you are looking at the only motor power and not the emotional vitals, because simple change of heart rate is important early sign of these things. Anta kada sir, avuna kada?
Avunu, we don't see.
The problem is when you are putting the patient on anesthesia, so starting lo unna heart rate ending lo unda leda, deep sedation lo deep analgesia lo unda leda chudu, heart rate ఎంత ఉన్నా కానీ పేషెంట్ కదులుతున్నాడు మాట్లాడుతున్నాడు తెలుస్తున్నాడు అని చెప్పి చూస్తారు. అక్కడ కదా మెయిన్ ప్రాబ్లం వస్తుంది. If you can look at the vitals stability for pre-op to the post-op, then these things will not come up kada, identification early avudi kada antan nenu ante as anesthesiologist.
That also induces, because patient is knowing what is happening during surgery, and he stress levels may increase and adrenaline surge will increase. Post-operatively, patient may go into stress cardiomyopathy if he is a vulnerable patient. That's what, even in spinal also, we have to sedate the patient and make him calm, or you have to stay with the patient and talk to him and give a emotional support. Usually we will give spinal and sitting outside. Everything is going on. Everybody is talking differently. That is something is going bad, bleeding, or it is not happening. I am unable to do this in a spinal case like fractures.
Not
So
only spinal, VA kudanu, where is the introduction of anesthesia preoperatively, talking to the attendants, establish relationship with the patient, then I am so and so an anesthetist ani malli kalustam repestamani anta chesinappude taggipotayi. Enni evaru chestunaru ippudu? ఎవరు చేయరు. కాకపోతే మనకి ఇన్స్టెంట్ స్ట్రెస్ కార్డియోమయోపతి తక్కువ కాబట్టి అలా ఏం లేదు, మనం చూడలేదు కాబట్టి. బికాస్ ద సేమ్ థింగ్, బికాస్ లైక్ ఎ పల్మనరీ ఎంబాలిజం we used to know only the post-mortem diagnosis. Later we identified. You only saved 1-2 patients in the intraoperatively when the arrest occurred and PE occurred. So the identification has come nowadays, and more depth of knowledge understanding has come. So that is the reason yesterday there was one talk by intensivist. Roju intensivist అని చెప్పి మామూలు చెప్తున్నాను. There was a talk of intensivist, who has to be a good intensivist. There are 4 components of it. Out of each one carries 25%. So 25% is the knowledge, 25% the skill. But these two doesn't matter, they have a good intensivist. They should have a 25% of the good attitude and 25% of the communication. All 4 completes the intensivist. So ఈ 4 ఉండాలి. ఊరికి నాకు చేసేసామన్నట్టు ఒకటి కాదు కదా. సో కాబట్టి all components are important when you are going to depth of the knowledge and physiology.
Yes, sir. Any questions from ఎవరు లేరా? మోహన్ రావు గారు, సతీష్ అన్న, సతీష్ జక్కిన ఎవరు రెస్పాండ్ అవ్వట్లేదు?
వాళ్ళు జిక్స్ లో ఉన్నారు.
జిక్స్ లో ఉన్నారా? ఓకే. ఏంటి సార్ మోహన్ రావు గారు ఏదో మాట్లాడతారు?
లేదు సార్, ఏం లేదు. సార్తో టాక్ ఇప్పించుకోవాలి, హౌ టు బికమ్ ఏ గుడ్ ఇంటెన్సివిస్ట్.
That we will do once I become a good intensivist, Mohan Rao. I will do only once I become good intensivist.
4 components we have to develop, sir. We don't know kada.
We have to develop
that 4 components.
So Mohan sir is going to talk on good intensivist. అది మీరు చెప్పండి సార్.
సార్ కమిట్ చేయొద్దు. నేను గుడ్ ఇంటెన్సివిస్ట్ అయిన తర్వాత చెప్తాను.
సార్ మీరు ఎలా
ఉండాలని చెప్తాను, గుడ్ ఇంటెన్సివిస్ట్ కానవసరం లేదు సార్.
అది కాదు సార్, మోహన్ సార్ మీరు అయిన తర్వాత మేము ఇవ్వాలి. సార్ అయిన తర్వాత మేము అందరం ఇవ్వాలి కదా.
అదే మరి, అందుకనే
డిలే అయిపోతాం.
because head of the Morton, you have to tell this talk. So
okay sir,
ఏంటి సార్?
ఏం లేదు,
మేము ఈ ఫ్రీక్వెంట్ గా చూస్తున్నాము ఇన్ ఐసియూస్.
ఓకే సార్.
పేషెంట్ ప్రెజెంటింగ్ విత్ సెప్సిస్, సెప్టిక్ షాక్.
అది ఇప్పుడు మామూలుగా వైరల్ మయోకార్డిటిస్, ఇన్ఫ్లమేటరీ మయోకార్డియోమైటిస్ అన్ని వేరు కదా.
అవన్నీ వేరు.
సో ఈ స్ట్రెస్ వల్ల వచ్చేది వేరు కదా. ఇప్పుడు ఫర్ ఎగ్జాంపుల్ yesterday we have a patient called Purnananda. So when he is on ventilator, when he is normally, he gets more emotional and cry and do lot of hangama when his wife or daughter somebody comes there, because he has a hallucination depression. So that he has more stress when they come to that. When they are not there, he is not stressed. He is normal. సో అలాగా స్ట్రెస్ ఇండ్యూస్డ్ మార్కర్స్ కూడా తెలుసుకోవాలి. వైఫా, కొడుకా, కూతురా, లేదంటే బయట ఎక్స్టర్నల్ లేకపోతే స్ట్రెస్ అని
వాళ్ళు లేరు అని కూడా స్ట్రెస్ అంటే మేబీ ఈజ్ ఎక్స్ప్రెసింగ్ మోర్. ఇఫ్ దే ఆర్ నాట్ దేర్ దే మేబీ మోర్ డిప్రెసివ్ స్ట్రెస్ బికాజ్ నోబడీ ఇస్ దేర్. అది కూడా ఉంటుంది కదా.
ఈజ్ ఆన్ dexmedetomidine or he is on sedation, he is on antipsychotic, so his coolly calmly sleeping and his vitals are stable. Yesterday I saw 3 times when relatives comes, his heart rate goes high and his blood pressure I didn't see, but I'm just telling you respiratory rate goes high.
He might be happy that by seeing them and is becoming more emotional
maybe.
So is it is it good for him, or if nobody is there, nobody is coming, and he might be feeling that nobody is coming, I'm on ventilator, what is going to happening to me? That also more depressive psychosis or depressive things also leads to, because I observed in Takasubo incidents, patient is calm, he is not talking, he is not responding to anything, he is whatever you tell also he is not communicating properly, he is in a severe depressive state and he developed Takasubo. Maybe it is more the reason for instead of somebody seeing and becoming emotional and tachycardia, that may not cause severe stress and severe surge of catecholamines.
సార్ దాంతో పాటు మీరు ఒక మాట, ఇంట్రా ఆపరేట్ కానీ ప్రీ ఆప్ కానీ వీ గివ్ అమ్నేసియా, యాంటీ అమ్నేసిక్ అలాంగ్ విత్ సెడేషన్, బికాస్ ఈవెన్ వై వీ గివ్ ఇస్ we give prophylactic sedation, not like once he needs or before, so that he does not remember the bad events. So in the ICU, why do we keep them into the sedation? You score for the Ramsey score, some other score, because you want him to be cool and calm, and having those kind of memory should not be there, because it's not a good memory. సో అది మనం మెయింటైన్ చేయాలి కదా సార్. సో అలాగే ఇక్కడ కూడా మనకు ఇప్పుడు ఏదైనా సరే మోర్ అండ్ మోర్ స్ట్రెస్ అండ్ స్ట్రెయిన్ లాగే మోర్ అండ్ మోర్ ఎమోషన్స్ డిస్టర్బెన్స్ ఉండకూడదు. మన గ్లూకోజ్ ఎంత కంట్రోల్ పెట్టుకున్నా ఇది కూడా ఎమోషన్ కూడా అంతే కంట్రోల్ పెట్టుకోవాలి కదా వాళ్ళ పేషెంట్స్.
అప్పుడు సెడేషన్ సరిపోలేదా పేషెంట్ కి?
మామూలుగా తక్కువ సెడేషన్ ఉందిలేండి, చెప్తున్నాను మామూలుగా. ఐఎమ్ నాట్ టెలింగ్ దట్.
ఇప్పుడు అలాంటి ఇన్సిడెంట్ జరిగితే కెన్ యు ఇంక్రీజ్ ద సెడేషన్ అండ్
అందుకే కదా సార్ మనకు స్కోర్ ఉంది కదా సార్, ర్యామ్సీ స్కోరు, ఆ స్కోర్లు ఉన్నాయి కదా, స్కోర్ మెయింటైన్ చేయాలి కదా. మనము ఇప్పుడు ప్యాడ్ గైడ్ లైన్స్ లేకపోతే వ్యాలీ గైడ్ లైన్స్ అవన్నీ మనం రెగ్యులర్ గా ఎక్కడ సార్ మనం బేసిక్ మిడ్ థింగ్స్ లో ఇంటిపేట్ చేసామా, సెంట్రల్ లైన్ వేసామా, నర్స్ ఉందా లేదా, పేషెంట్ కి పొజిషన్ ఇచ్చిందా లేదా, ఆ లెవెల్లో ఉండిపోతున్నాం, నెక్స్ట్ లెవెల్కి వెళ్ళట్లేదు కదా. దట్స్ వై కోవిడ్ లో there are 10 years బ్యాక్ వెళ్ళిపోయింది వెంటిలేటర్ ఐసీయూ కేర్, బికాస్ ఓన్లీ ట్రీట్మెంట్ వెళ్ళిందా లేదు చూస్తున్నారు, ఆల్ సరౌండింగ్ థింగ్స్ వీఆర్ నాట్ లుకింగ్ ఇన్ టు ఇట్ కదా
సార్. అలా చూడాలంటే సార్ వీ హ్యావ్ టు ఫాలో ఎంటైర్లీ ఇంటర్నేషనల్ గైడ్ లైన్స్. ఇంటర్నేషనల్ గైడ్ లైన్స్ ఇస్ ICU means only 12-bedded ICU only, sir, which is not practical in, which is not at all practical in corporate setup.
కార్పొరేట్ కాదు, ఎక్కడైనా సరే when the ratio is good only we can do either doctor's ratio, equipment ratio or nurse ratio 1:1 ఉంటేనే చేయగలం, డాక్టర్స్ 1:10 ఉంటేనే చేయగలం.
Still I appreciate CMC Vellore, they will restrict to the 1 unit to the 10 to 12 beds only, sir. If you are there opening another ICU, they have to appoint new faculty, new entire team.
అదే సార్, అది కార్పొరేట్ కాదు సార్, అది గవర్నమెంట్ కాదు,
కార్పొరేట్ కాదు,
రెండు కాదు. గవర్నమెంట్ లో చేయలేరు, కార్పొరేట్ లో చేయలేరు, అలాంటి చోట చేయగలరు.
But we have to streamline the things by putting the guidelines, to putting the protocols, sir.
ఆల్రెడీ పెట్టారు సార్, ఏసీసీ వాళ్ళు పెట్టారు, కానీ ఫాలో అవ్వరు కదా డబ్బుల కోసం జనాలు. మొత్తం నడిపిస్తారు. ఒక్కొక్క హాస్పిటల్ ఒక ఇంటెన్సివ్ స్టేట్ ఎక్కువడానికి లేదు అంతే అంటారు, ఎవరు జూనియర్స్ పెట్టమంటారు, రకరకాలు ఉంటాయి కదా సార్.
అంతే సార్,
కార్పొరేట్ లావదలే కానీ సరే సార్.
But we should know what are the minimum things required.
Yes, sir. Nice presentation, madam. Anuradha garu.
Thank you, sir. Sir, can I add one point?
No, any point can add, say good.
So stress cardiomyopathy means surge of catecholamines. So in COVID-19 pandemic, everyone is physically, emotionally stressed. Not only patient, family also stressed. So that's why after COVID time is a stress cardiomyopathy percentage is increased compared to
Increased,
before COVID.
Increased,
Yes, sir. Like,
we have
increased, sir.
data on that. We have data on that.
Yeah, one point ఉంది అది ఇచ్చాడు ఆర్టికల్ లో ఉంది ఒకటి నెక్స్ట్ నాట్ ఓన్లీ బ్రోకెన్ హార్ట్ సిండ్రోమ్ హ్యాపీ హార్ట్ సిండ్రోమ్ ఆల్సో ఇస్ దేర్ దట్ మీన్స్ ప్లెజెంట్ ఎమోషనల్ స్ట్రెస్ ఆల్సో ఇస్ వన్ ఆఫ్ ద హ్యాపీ హార్ట్ సిండ్రోమ్
హ్యాపీ హార్ట్ సిండ్రోమ్ అదే ఏదన్నా హ్యాపీ థింగ్ వచ్చినా కూడా స్లోగా చెప్పాలి.
ఏదైనా ఎగ్జామ్ రాసిన సడన్ గా పాస్ అయ్యానని చెప్పేసి నాకు డేంజర్.
మెల్లిగా చెప్పాలి. సార్ మీరు మొన్న ఎగ్జామ్ రాశారు కదా, ఆ రిజల్ట్స్ అంటే ఇప్పుడు బ్రోకెన్ హార్ట్ సిండ్రోమ్ అసలు ఇది
హ్యాపీ హార్ట్ సిండ్రోమ్
ఏది ఎక్కువ ఉండకూడదని దీని అర్థం. ఫైనల్ గా అదేగా నువ్వు చెప్పేది. టూ మచ్ హ్యాపీనెస్ ఉండకూడదు, టూ మచ్ స్ట్రెస్ ఉండకూడదు, మధ్యలో ఉండాలి.
సో ఫాలో ఇకిగాయ్.
సరే అనురాధ, ఇట్స్ ఎ నైస్ ప్రెజెంటేషన్. We will close the session.
Yes, sir.
Thank you all for active participation. Thank you.
డేవిడ్ సార్,
సార్
మీరు చెప్పిన దానికి అర్థం అంటే ఫాలో ఇకిగాయ్.
గయ్యా అదేంటి?
ఇకిగాయ్ చూడండి, నెట్ లో చూడండి తెలుస్తుంది.
అలాగే సార్. ఓకే,
థ్యాంక్ యూ సార్.
థ్యాంక్ యూ.
థ్యాంక్ యూ టు ఆల్.
అనురాధ.
Thank you, sir, David, sir. Thank you to all.